I'll be just giving a brief description about what are the various nerve transfers in brachial plexus injuries, and I'll start with the overview of my presentation. The schema will be about the clinical evaluation and algorithm for making a decision. Then what are the various approaches in different type of presentation, and something about the recent advances in the nerve injuries, nerve transfers. So clinically, we start with the intention, with the goal in our mind as to we have to localize the lesion, see the extent of involvement and the severity. Severity means whether it is an avulsion or rupture. Extent means what is the involvement of which type of roots or the or either it is a upper trunk or an extended upper trunk or a global, and to localize like the roots. So the best way is to examine, to go in a sequence from the origin towards the distal. So we go from the roots to the trunk, divisions, then cords, and then the branches. Just to localize the lesion, like for C5, we would go for examination of the deltoid, for C6 biceps, for C7 triceps and wrist extensors. C8 will be the extrinsic hand muscles, and for T1 will be the intrinsic hand muscle. So it is for the student, if you are asked that to tell one examination which will localize your lesion. So this is that overview. Otherwise, you go and examine the entire array of the muscles. So again, the basic steps for the postgraduates, which I would like to emphasize, is that the proper exposure of the bilateral limb from the starting the entire upper torso should be exposed. Not even a banyan should be there. Patient can have a lower, and then the entire back and the front of the chest and both the arms should be visible. Then attitude of the limb as visible should be described, and then the muscle wasting should be commented, and the next point will be the scars either from the injuries or the previous surgery, as we do it in details under the heading of inspection and palpation. And if there is any deficit of the soft tissue, or if there is any visible joint contracture, and the bony abnormalities if there is any associated fracture leading to that bony deformity. So the first thing when we see at the faces of the patient is to exclude the Horner syndrome. So look for the telltale signs. If there is a ptosis, meiosis, anhidrosis, or enophthalmos, and that signifies that it is the involvement of the lower trunk also. Because as you can see, I have mentioned that T1 sympathetic ganglion lies in close to the T1 nerve root. So that's given indication towards the lower trunk injury and also towards the root avulsion. Then we have, you have to look for the elevation of the hemidiaphragm in the chest X-ray, which is usually prescribed as in full inspiration and full expiration of the patient. And then we'll see the level of the diaphragm comparing both the X-rays. Also look for the involvement of the rhomboids and the long thoracic nerves, because if any of these findings are present, it indicates that the lesion is a preganglionic. And look for the tendons. Gently tap in the posterior triangle and also in the infraclavicular area. If there is sudden acute onset pain and tingling, it indicates a rupture. And if there is a no tenderness, that indicates an avulsion. So these are the rough guidelines. How are you going to localize your lesion, and also the extent of the involvement. Look on the shoulder from the lateral side if there is a presence of sulcus sign. This may be due to the glenohumeral instability. Most of the time patient comes as giving a complaint like there is a dislocation, but this is no dislocation. It is just that the hold of the deltoid muscle is lost that leads to this glenohumeral instability. Then the sequence of examination to localize, as I have already mentioned, we will go from proximal to the distal. So for the roots, we are going to see the action of the rhomboids, which is supplied by the dorsal scapular and the serratus anterior, to look for the long thoracic nerve. And in the trunk, you all know that we look for the suprascapular nerves. Then for the cords, we have the medial and the lateral pectoral nerve. We'll look for the action of the pec major. for the subscapularis muscle and also for the latissimus dorsi. For the dorsal scapular nerve, you should stand behind the patient and just put your right hand in the small back as it is seen in the first figure between the two scapulae, and ask your patient to flex this elbow of the affected side and try to push up. And you will, if the rhomboids are intact, you will feel a push on your hand, an outward push on your hand. So that is how you check the rhomboids muscle. For the serratus anterior and to look for the winging of the scapula, you know the test is push the wall. Then for the supraspinatus, you examine from the front, ask the patient to do an abduction. This I'm showing a normal supraspinatus muscle. If the patient is able to do or not, the palm should be pointed downwards. So here you can see that the left side is the affected, right? I am trying to show you the normal action of the supraspinatus. For the infraspinatus, you adduct the arm and do the external rotation at the elbow and provide a medially directed force to look for the infraspinatus. Then both the heads of the pec major should be palpated separately, the sternal head and the clavicular head in the infraclavicular area. Then for the thoracodorsal, you know that you ask the patient to abduct the arm and push, and in the meantime, you are putting your hand at the posterior axillary fold to see whether it is getting taut or not. The sequence of examination in the branches when you want to localize. The initial was for the trunk, for the roots and the trunk. Then for the branches, you go for the axillary nerve. Then you will look for the action of the deltoids. You will see the biceps and the brachialis. And as I mentioned earlier also, the triceps and extensors will be for the radial nerve, and the flexor muscles of the forearm and hand for the median and the ulnar. So deltoid, again, the anterior fibers and the posterior fibers should be examined differently, separately. Like for the anterior deltoid, you make the patient to sit and ask his hand to rest. And then an outward, he will try to abduct and he will put a downward pressure. And for the posterior deltoid, will you examine on the posterior part where the deltoid, as you can see in this picture. For the biceps, you know that the biceps are the flexor of the elbow in the supination. You can check it. But here you have to be careful of the brachioradialis. In intact radial nerve, sometimes the brachioradialis works and it gives an impression as if the elbow flexion is present. So be cautious about this. Triceps, you know, you just ask the patient to abduct the entire limb and then the flex, keep the hand back. And then he will try to extend his elbow and you are in the meantime palpating the triceps muscle, the wrist extensor, the finger extensors. You all check it as you check in other nerve palsy. I'm not going into details. For just pinpointing whether the median nerve is also involved, you look for the pen test, and which is testing the abductor pollicis brevis and also the long flexors, that is the flexion at the PIP joint for the FDS. For the ulnar nerve, you will look for the flexion at the DIP joint of the little finger and all those tests which we have seen earlier shown by Karthik. In the last, do not miss the examination of the donor nerves. It will go in sequence with the examination of the plexus also. So look for the trapezius action, look for the chest x-ray to see whether the phrenic nerve is intact, and also the intercostal nerves where again you are just ruling it out if by taking the history, whether there was a history of any chest injury, any rib fracture, any placement of intercostal tube or something, and also the contralateral brachial plexus, C7. So this is the way you examine the trapezius, and you always compare with the other side also, the normal side. So what we usually do, we always examine the normal side first to know the strength of that particular muscle, even when we are examining the brachial plexus, and then we go on the affected side. And for the chest x-ray to rule out the phrenic nerve. This is just a sample, a template for how a motor function assessment chart. I think every center develops their own motor function assessment chart where they document what are the motor findings which are deficit. But in general, it is similar only. For the sensory also, you must know the zones of dermatomes so that you can localize. As you can see in this clinical picture where we have just tried to mark each and every dermatome of that particular zone. So both in the anterior. So even during your examination, during your long case presentation in your exam, you must keep marking this. And you can see that the shaded area, it shows that there is either hyposphagia or anesthesia. Whatever you find, you are going to record and present. This is a sensory function assessment chart. Then do not miss to check the reflexes. You have the biceps reflex, you have the triceps and the supinator reflexes. And obviously, both the arteries should be seen. Then the investigations, you all know for the decision making that we usually go for the MRI, and the contrast enhanced MRI can show these features so that you can just make a difference between whether there is a root avulsion and whether there is a root rupture, so that you can decide upon your course of action. As you know, in avulsion, you have the only option left is for the nerve transfer. In rupture, you can go for maybe a nerve grafting also or a repair. We also go and do the nerve conduction studies and the electromyography according to our clinical findings, whatever it is, either a global plexus palsy or a upper trunk palsy sort of thing. So again, I'm not going into details. These are the other investigation. If facilities are available, you can go for the electroneuromyography and even the sensory evoked potential. At our institute, these are not available. So we usually go only for the MRI, NCS, and the ATAMAX EMG. So now how to make a decision for the surgical intention? Here I have just mentioned for the sake of the knowledge of the PGs that which cases require the immediate exploration. So whenever there is an open penetrating injuries like a stab injury, something like that, or you go and directly explore it in emergency if the patient is stable. If there is an associated vascular injury, and as we see that anyways the cardiac surgeon are going to explore the supraclavicular artery or subclavian artery or something, then in the meantime, you can go and look for your plexus also. Then the management where you can go for this conservative, where you are going to take the decision whether to go for exploration or not. So sometimes you get low gunshot injuries patient, and if you find no disruptive lesion on the MRI, only there is edema or the tunnels is progressive. In all these cases, you can wait and watch. For delayed exploration, if you find a pseudomeningocele, this basically indicates the root avulsion at many levels. And so these are those closed injuries where you wait for, like book says, till 5 months. But even if you get a root avulsion, you can explore as early as 3 months, where there is cervical fractures and the patient requires the cervical fracture to be stabilized. Then you can wait and go for a delayed exploration. These are the surgical options available in the brachial plexus. Let us go directly to the nerve transfer approach in the upper trunk palsy. So for upper trunk palsy, you are supposed to restore the shoulder abduction and the elbow flexion. So if the injury is less than 6 to 9 months, you can go till 9 months, as we have tried in children also, it works well. And especially when the nerve transfers are close to the muscle. So like spinal accessory to suprascapular. If it is slightly late, then posterior approach is preferable. If it is comes patient, you are exploring at 3, 4, 5 months, then you have the choice depending upon your technique. You can go both for the anterior and posterior approaches. Somsak is another for the upper trunk where C7 is intact. You can jolly well use a nerve to the long head of triceps to renervate the anterior branch of the axillary nerve. So these two transfers will lead to the restoration of the shoulder abduction very well. And then the Oberlin's 1 and 2 for the elbow flexion. So, when the patient is presenting early and is in the time period for the nerve transfer, try doing this. After 9 months, usually the nerve transfer do not work well, and there you have to go for the muscle transfers. So, here I'm just putting one picture. What are the classical incision marking for anterior approach nerve transfer of spinal accessory to suprascapular? And this works very especially who are early. So in the patients who present early, we try this. Otherwise, for all purpose, we have switched over to the posterior approach because literature also shows that posterior approach has its own advantages of not only coapting near to the muscle, but also it obviates if there is a double injury, including injury in the suprascapular notch. So our practical experience is also that posterior approach results are better as compared to the anterior approach, but it varies from center to center. Then this is the SOMSAT transfer. This the one advantage of the posterior approach of spinal accessory to suprascapular was that we from the same approach we are able to do the posterior approach of the SOMSAT transfer. So it becomes very easy for us that in the same position we do both the nerve transfers. And this is the result if you go for both nerve transfer for the shoulder. This is the pre-op and this is the post-op. As you can see, it was a then for the Oberlin's, one or two, depending upon availability of the ulnar and median nerve. Sometimes what happens in upper trunk injury also, some component of lower trunk injury is also there and you might have only one nerve. So depending upon the availability, you go for Oberlin's 1 or Oberlin's 2. So this patient is of actually one of my relative only. So I like keeping his picture because I was very satisfied when I see his outcome, and I was happy that I need not require to refer my own relative to some other center. So in extended upper trunk, where C7 is also involved, there are other nerve transfers also, which has come for the posterior interosseous nerve innervation also. But by for all purpose, for the wrist and the finger extension, I usually go for tendon transfer. And again, after the 9 months, a muscle transfer is the option. So these are just the pictures of my same relative where you can see we have harvested the pronator teres and just showing the carpi radialis longus and the brevis also. And this was his result of the wrist extension after the tendon transfer and also of the MCP extension. The same patient, we did it two stages. One was the Oberlins and the for the shoulder and the other was for the C7. So like if this is a total or a global palsy, then the same thing for the shoulder goes. For the elbow flexion, since Oberlins is not an option, intercostal nerves are available as the donor. But personally, I have not got good results with the intercostal nerve since my residency days, so I do not practice much. I straight away go for a free functional muscle transfer for the elbow flexion. I'm very confident and till date I have not lost any of the gracilis and with good results. Most of them have 3 by 5 and some of them are 4 or 5, 4 by 5 also. And then later on you can go for a wrist arthrodesis and if the patient comes for the finger flexion also, we go for a second free functional muscle transfer. And the another thing for the finger flexion, which we have started recently, is inspired by Ganga Hospital results and their techniques and a very elaborate discussion with Dr. Hari sir also. We have started magnetic gloves also, where there is no scope of the second free functional and whether the patient also does not want to go an extensive surgery and a very long waiting period. So we have started using magnetic gloves and it is working well, at least up to the patient satisfaction level. So these were the initial photographs where I was using the intercostal nerve to renervate the musculocutaneous nerves, but with very limited results. Then for the muscle transfer, as I told, if the patient comes late, usually after 9 months, we practice to do the trapezius transfer. And even the literature also says the same thing. So trapezius is a good muscle for the transfer and you can do it very fastly. Just fix it with the screw and check for its like bony union after 3 months with an X-ray and a proper physiotherapy protocol, you can see the patient achieves a good result of the trapezius transfer also. And for the like free functional muscle transfer, initially we were using the intercostal nerves again without satisfactory outcome. As you can see in this patient, we had a contraction and a 3/5 some kind of thing. So later on, we have switched over to the donor as the spinal accessory. So from posterior approach, we do a nerve transfer of a spinal accessory to the suprascapular. And in the second stage, immediately after 3 to 4 months, we go for a free functional muscle transfer for elbow flexion using one of the anterior branches of the spinal accessory. So you can use the spinal accessory nerve for both the purpose if you are doing it from the posterior approach. And these are just the fixation of the nerve and without any skin paddle, we are using the gracilis. We just keep the muscle window for 48 hours, monitor for the vascularity, and then we close it with the leftover sutures, which we usually put it during the intraoperative time only. So these are the patients in which we had a good results with the spinal accessory. So for now onwards, I mean, for last so many years, I'm not using musculoskeletal. In lower trunk palsy, usually we go sometimes for the nerve transfer. Recently, we have started, so we are still waiting for the results that a branch of pronator quadratus. We take it and try to innervate the median nerve, but then we are still waiting for the results. These were our previous cases where we directly went for the tendon transfer in the lower trunk injury. And these were the results of the patient. So advances why I am putting here because which the nerve transfers which I am not doing, you should be aware of it. Somsak is also one of the advance and luckily we have been doing it very routinely. You know that that Somsak belonged to Thailand and he reported a very good result with his transfer and posterior approach allows better views which we have started practicing for last couple of years. And then the serratus reanimation is one advance which has come nowadays, which was also like given by Arparo Zikrit. It was also from the Thailand only. I searched for some literature. And as you can see, the lateral branch of thoracodorsal nerve is used to renervate the long thoracic, which supplies the serratus anterior. Then, as I was telling you, in the isolated lower trunk palsy, the muscle branch supplying the brachialis has been used to innervate the median nerve and sometimes the nerve to pronator quadratus also we have been using. So this, if there is a median nerve is intact and only lower ulnar nerve is involved. So this study was from China, who first Zheng et al. Reported. And the centers who practice, they say they get good results. I am yet to get the results of these nerve transfers, especially in the lower trunk. So this just I have put a picture from one of the articles by Dr. P.S. Bhandari, sir. He routinely does this nerve transfers for the lower trunk. And then the pre-spinal route using the contralateral C7 nerve route. I'm also yet to use the contralateral C7 transfer. But as we see in the brachial plexus meeting also, and as I keep on talking with the stalwarts, Hari sir will also agree that this works very good. And with like practice, the technique is also easy and user friendly. So Wang procedure is one where you just shorten the humerus something and then you do a contralateral C7 transfer. So then there is one advancement which I did not come across any Indian study, but Karlstead et al. He has mentioned in one of the study that even at the spinal level, these roots which were avulsed, they can be replanted into the spinal cord, and they have got good recovery in the shoulder and the proximal arm muscles. So these are the advantages which are working, and I think the centers which are using they basically combine with these regenerative cell technologies also. All those stem cells, so basically the neurosurgeons, they are very fond of the stem cells use, especially in their spinal injury, spinal cord injuries. So they are like trying to use these regenerative cell technologies in the cases of brachial plexus injuries with root avulsion. So I just a very small 1 minute for how I started my journey. I started in 2018 only when I conducted one brachial plexus workshop at my center at AIIMS Patna, where I was the only plastic surgeon then, and Dr. P.S. Bhandari sir was the resource person. And basically the journey also started beforehand when I got my thesis on brachial plexus, the secondary procedures. So this I like to share with the PGs that if you get a thesis of brachial plexus, do not get disheartened. At my center, I was made a mockery that okay, all the patient with hanging their upper limb, they will come and looking for you, and you will not be able to provide any success to them. But it is not like that. So I completed the thesis, also got my results also, and I started it at AIIMS Patna also. And then like we have been doing these procedures since 2018. So just numbers are just a matter of time. And recently we have started one or two cases of ipsilateral C7 transfer inspired by one of the articles in the PRS which was published in 2022. In this, basically, a fascicle of the C7, which was supplying the PEC major, was transferred to the suprascapular nerve. But then I found that this is possible, but the results are good only when the patient presents early. Like this case, we did it at the 3 months of injury only. He has a root avulsion, and we tried doing this technique. So he has a good result, but all those patients who come late, again, the result is not that good because anyways, this is again one anterior approach and even the nerve transfer is slightly farther. So here we are checking the contraction of the pec major muscle by stimulating the fascicle of ipsilateral C7. So this was that child in which we did, and we got some satisfactory result. But then we have stopped it because no other results we are getting in the patient who are presenting for longer terms. So key points are that for especially for the PGs, for the beginners, the plexus gives you an impression of a network and a cobweb. And like me, you might also get scared, but don't be. If you have read the anatomy and if you have get some hands-on cadaveric dissection, it is one of the easiest plastic surgery, I would tell, with the most gratifying results because it is like a mathematics. You know what are the deficits and you know what are the techniques. And if you do your techniques well, then the outcome is definitely satisfactory. Then again, the initial dressings I prefer to be done by myself only or whoever is the operating consultant and not by the assistant. And physiotherapy is important, especially in cases of the muscle transfer, because in one of our trapezius transfer, we lost the transfer because we sent it to the physiotherapy. It was one of the initial case, and then they had a forceful adduction sort of thing which just snapped away the bony union which was there. So after that one case, we keep on doing our physiotherapy, and then later on we have one physiotherapist in our department who understands our requirement. And then the most important part is the finances for any brachial plexus. The patient should be financially good. So there are many government funds. You also, as PGs, you should be aware whenever you are working either in a corporate setup or in a government setup. And then the special clinic for the BPI patient is required. Either you keep it for a half day or even for 2 hours at your center in 1 week. because those brachial plexus patients who are recovering can interact with the patients who have already recovered. So motivation is equally important for these patients. And lastly, the patients, both on the part of the surgeons and the patients. So I always relate the management of the brachial plexus injury with the critical thinking skills. You know, critical thinking skills are basically the problem solving skills, thinking about your own thinking. So this skill has to be practiced from the very beginning of your MCH or DNB training of the plastic surgery, because we are the problem solving specialty and our problem solving skill should be better than the others. So thank you so much. And in the last, I always believe that God is the one who is the patient. We only treat them. Thank you. Thank you once again for your patient listening.
Just a word about Karlstedt, which he had presented. So when the team had come to Ganga, they also presented here, but it is sort of given up procedure. Nobody does it now because the results are not consistent. And it's a very major surgery to open the spine and put the roots inside. The root implantation, except for the Stansted unit in UK, Stanmore, nobody else does it. But opposite C7 is a very promising procedure. That is Wong procedure. We personally don't do because we have a different system where we follow. We go by the spinal accessory to musculocutaneous and secondary procedures. So ideally, it is better to have everything under your umbrella. That means all the only you can offer the comprehensive treatment to the patient. It is not that you alone have to do everything. You can team up. Like in our unit, today we have done close to, I think, 8 brachial plexus reconstruction and in one day. So I think it's a great promising field because the number of patients actually are increasing and they're all young and the affordability is also increasing. So if you are able to do it quickly, getting around to the magic glove is very nice. Today we had a monthly meeting of plastic surgeons of Coimbatore, and one of the surgeons, I didn't know at all that he had ordered a glove for a traumatic patient who had no finger flexion. He had a major crush injury, and that patient finally is now using the magnetic glove and eating and doing. So for the benefit of others, we are actually planning to publish it very soon.
Thank you, sir. Thank you.
Thank you, sir.
Veena, it is a guest.
Sir.
Yes, sir. Yes, sir.
It is a guest because I am not supposed to ask you questions. But anyway, luckily, yesterday we had a trapezius and also a free functional muscle transfer.
Oh, great. Great.
So it is a good learning for the residents. In fact, Dr. Bhandari came for a operative workshop live. He operated 11 cases. So prior to that, we have been doing grafting for the intercostals. But after his demonstration, now we are giving directly the intercostal harvesting and it can be done. And results are very good also. So it all depends what you rightly told, that you have to choose the patient and the merit of the patient has to be considered. So nicely, Dr. Hari Venkatara nicely told that once you start doing things and if you have everything on your umbrella, so like a good batsman, you can play any balls, no problem. Only one thing I have to ask, you choice between how many cases phrenic nerve you have used as an active nerve?
So, sir, I have not personally used phrenic nerve. I
Because,
have not been required to use it.
Because free functional transfer, sometimes you get the spinal accessory either used or spinal accessory is very thin enough to do
So
a activation of a muscle.
when we don't get the spinal accessory, we are lucky enough to get sometimes the lateral pectoral or the medial pectoral nerve also, with which we
what happened last before day before yesterday, we couldn't get a good spinal accessory. So obviously you have to take the phrenic nerve for the harvesting for the free functional muscle transfers.
So the another option is that if intercostals are available, you can use it for the free functional.
It is already been used. That was the problem. Thank you.
Like you asked about phrenic nerve. We usually use phrenic nerve when we are doing a Wang's procedure where we connect the phrenic nerve to the PDLT, posterior division of the lower trunk. So that is probably the only time we are using that currently, which gives a very good result. The only thing is that after phrenic nerve and for intercostal nerves, the physiotherapy post-op, jogging, running, climbing upstairs, those things are very important. But results are good. Consistently,
I don't know,
results.
Dr. Bhandari was speaking once.
Manish Subhashri is asking approach to a failed FFMT for elbow flexion in a panbrachial plexus. So if one FFMT has been failed, the next you have to do is the next only. For elbow flexion, there is no much option in a panbrachial plexus because you don't have pec also, nothing. So you go for a second. And then there is one more question. Can we explore immediately and repair at trunk level and division? Yes, yes. If you find there is a, like in the pre-op investigations also, if there you find a rupture, then you be prepared for that. And if you on the exploration, you find that there is neuroma or there is a length which is scarring, be prepared for repairing it with using a nerve graft, both at the trunk and the division level. I hope Hari sir would agree with me, otherwise he can add his inputs. Sir, you do.
Yes, we can. The only other donor we are trying to explore now is if you don't have any donor, you can take the opposite spinal
yes,
as low as possible, and it will come somewhere close to the just like Wong. You bring the spinal accessory with a short graft, and then connect it to the functioning muscle transfer.
So one case, Hari sir, we also did. We could not get pre-operatively only spinal accessory was not present, and we planned for a nerve transfer because he was at 4 or 5 months of injury only. So we did a contralateral. We took from the posterior approach. We took and then via the help of a nerve graft, we neurotized the suprascapular. So you said well, contralateral spinal accessory is a good option.
Karthik, won't the latissimus dorsi be involved in BPI? How can we use it for shoulder mobilization?
So it depends upon the what type of a brachial plexus injury is there. If it is not a panbrachial plexus, so latissimus dorsi is available in cases of upper trunk also injury. It is available. And for shoulder mobilization, like personally, I have not used for shoulder, have read only, but latissimus dorsi has been used for the elbow flexion. So, sir, Hari sir, if you have used latissimus dorsi for shoulder abduction, I have personally not used
No.
it.
We prefer the trapezius, so always trapezius is there. So trapezius transfer only for shoulder. Latissimus dorsi for
elbow flexion sometimes. So, Karthik, is it clear to you, or we understood your question well, no?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
The next question is, what is timing of imaging or investigations?
So, for the timing, like we discussed, the NCS and EMJ should also be done after 4 to 6 weeks only to have the findings. MRI is usually actually done in the initial only, just to see whether there is any pseudomeningocele available or not. But anyways, if you are planning to explore, you should get fresh investigations done at that time also. Because many a times patient come up with the MRI report done from outside, and it was immediately after the trauma where only says something like edema or sometimes like the pseudomeningocele only. But later on, before proceeding for surgery, you must get one repeat MRI done. And NCS and EMG are very clear. After 4 to 6 weeks, you can do it for the documentation only.
Phrenic nerve as a donor nerve.
That was discussed. That's why I did not answer.
And the second question is, when doing spinal accessory to musculocutaneous, can we use the lateral cutaneous nerve of arm as a graft instead of sural nerve graft?
Yes, why not? You can use
Lateral,
it.
yeah.
Yes, sir.
Lateral is a little difficult because it goes very low down. We routinely use medial cutaneous nerve. It is perfect size, matches the muscular cutaneous also. You can get 25 centimeters of medial cutaneous nerve of forearm, MABC. We presented in the last meeting also in the Indian AIIMS Society. I just sent it and we compared it with Sural and found both the same. I always feel
The latissimus dorsi be involved in BPI. How can we use it for shoulder mobilization?
So it depends upon the what type of a brachial plexus injury is there. If it is not a panbrachial plexus, so latissimus dorsi is available in cases of upper trunk also. Injury, it is available. And for shoulder mobilization, like personally, I have not used for shoulder, have read only, but latissimus dorsi has been used for the elbow flexion. So, sir, Hari sir, if you have used latissimus dorsi for shoulder abduction, I have personally not used
no.
it.
We prefer the trapezius, so always trapezius is there. So trapezius transfer only for shoulder. Latissimus dorsi for
Elbow flexion sometimes. So,
Question is, what is timing of imaging or investigations?
So for the timing, like we discussed, the NCS and EMJ should also be done after 4 to 6 weeks only to have the findings. MRI is usually actually done in the initial only, just to see whether there is any pseudomeningocele available or not. But anyways, if you are planning to explore, you should get fresh investigations done at that time also, because many a times patient come up with the MRI report done from outside, and it was immediately after the trauma where only says something like edema or sometimes like the pseudomeningocele only. But later on, before proceeding for surgery, you must get one repeat MRI done. And NCS and EMG are very clear. After 4 to 6 weeks, you can do it for the documentation only.
Nerve as a donor nerve.
That was discussed. That's why I did not answer.
And the second question is, when doing spinal accessory to musculocutaneous, can we use the lateral cutaneous nerve of arm as a graft instead of sural nerve graft?
Yes, why not? You can use
lateral,
it.
yeah.
Yes, sir.
Lateral is a little difficult because it goes very low down. We routinely use medial cutaneous nerve. It is perfect size, matches the muscular cutaneous also. You can get 25 centimeters of medial cutaneous nerve of forearm, MABC. We presented in the last meeting also in the Indian AIIMS Society. I just sent it and we compared it with Sural and found both the same.